Hey, top of the morning to you. A little early, but hope you guys are able to hear me okay. Good morning. Thank you all for joining me. Likely too early, but that's all right. Perfect. Two things I like to be loud and clear. Hello, hello. We'll get started in just a couple minutes. Feel free to post any questions you have. I'll knock this out, and then I'll see you guys this afternoon for the lab for grand rounds. Should be fun. I don't even know what the case is yet. Just to verify, linezolid is contraindicated with SSRIs and MAOIs. Generally speaking, I would not want to mix those two together. I would not say it's an absolute contraindication. I would just be monitoring pretty heavily for that. So like, you may have some instances where you have someone who, is on an SSRI and then they, sort of emergently need linezolid. And that would be a case where you could do the two together, and I would probably discontinue the SSRI if possible while they're on the Zyvox. So, not ideal, but sometimes you have to do it. It's always good to think about it, though, at the very least. And don't forget, you guys have an assignment due on Friday at 11:59 p.m., I believe. So, that's right. It's about you would monitor for serotonin syndrome. So, that would include like looking at their heart rate, blood pressure. You expect those to typically go up. In that case, there you look for like increased sweating, changes in mental status. They could have seizures, and the big thing there is the sort of musculoskeletal effects. You can see like increase in clonus. You can get rigidity. The big differentiator there between that and like NMS or neuroleptic malignant syndrome is you'll see that with NMS is more classically described as having like lead pipe rigidity. They probably won't be as stiff with serotonin syndrome. And that'd be all meds that have reactions with high tyramine containing foods. Generally speaking, yes. Hey, Tochi. No problem. Wow, so many of you guys logging in this early. I'd like to say I'd be able to do the same if I was in your shoes, but I'd probably sleep in if possible. All right, well, it's 8 o'clock, so let's get started here. All right, let's see. I don't have any questions up on the board, so I will just jump straight into the PowerPoint, which is here. So we discussed sort of all the concerns with pregnancy and labor and all that good stuff. Now let's jump into hormonal therapy. And so we're going to spend a lot of time talking about our estrogens and progestins. And I apologize if you hear a 3-year-old banging on the door to try to come in. That would be Phoebe, and she needs to understand her boundaries. So that's why I locked the door, but that's all right. Anyway, so let's talk about the menstrual cycle. And basically, and I'm sure you've covered this elsewhere, but, I'll kind of put my little bit of spin on it here. Essentially what we're seeing is that typical sort of HPA axis here, or very similar to the HPA axis, but basically Bring Phoebe to school. You guys don't want to bring Phoebe to school. She has to go to school herself, so she'll be busy with that. Anyway, so looking at this, we are going to see the hypothalamus is going to be releasing gonadotropin releasing hormone. That will then affect the anterior pituitary, releasing luteinizing hormone and follicle stimulating hormone, and then that will have positive effects on the ovary. And we'll see two of the big components that we're going to form here include estradiol and progesterone. All of this will have negative feedback. So if you have high levels of estradiol or progesterone, that will then feed back and inhibit both the pituitary and the hypothalamus. And we can use that to our benefit. We can try to modify the system here to attempt to maybe suppress the menstrual cycle. Sometimes we can try to use it, in some cases where this is not functioning well, we can try to modify it as well by maybe supplementing some of these products here, as we will see. So, and again, you've likely covered this before, but just to reiterate, typically, if you think about the typical 28-day cycle, and of course, this is different for some people, you may find it's longer or shorter. I want to focus on sort of the changes in hormone levels that will happen throughout that 28 days there. And you can see sort of the development where you have like the follicle being developed here and it'll release the egg and then get converted to that corpus luteum. But basically what you'll see with the gonadotropins being LH and FSH primarily, you're going to see it kind of goes throughout its normal cycle there and then kind of resting levels, and then you'll see around day 14 you get this big spike in luteinizing hormone. And then you see a little bit of spike in FSH as well, and then they'll kind of dip back down to their normal levels there. But the big deal here is that once you have that egg release, you're going to have estradiol levels also peak up here as well. And then they'll dip back down, and then eventually you're going to see progesterone will sort of pick up in towards the latter half there. So kind of days 21 through 28 will have the kind of the peak of the progesterone levels. So point being there is that by recognizing that you have changes in levels throughout the month, you can sort of mimic this with medications. And so that's when we get into, for instance, with our different types of birth control, we're going to see that, you can have static levels of drug throughout the month, but in some cases you may find that you'll do things like having, you may have dosages which will change throughout the month to try to mimic this pattern. So if you ever hear like triphasic or biphasic or monophasic, that's what we're talking about, is actually changing the doses throughout the cycle there, or throughout the 28 days. But anyway, so we see that, disturbances in ovarian function is relatively common, and it can be due to lots of things, right? It could be issues with the pituitary gland, it could be issues with the ovaries, it could be cancerous, it could be lots of different things there. And you'll find that, even some minor disturbances may be sort of self-limited in some cases. So, for instance, if you're having patients with like extremes of like diet and exercise, I typically think about like younger, like, cross-country runners. Like I think about that, like, having like a high stress sort of exercise regimen can sometimes cause, a suppression of menstruation in some cases there. And that's generally self-limited, right? So, if they abstain from the exercise, and that generally will kind of go back to normal. But anyway, so we'll find some ways we can try to manage this by either supplying extra hormone or maybe restricting it. We'll see there's different ways we can do that. So anyway, with estrogens, we'll find that estradiol is the primary secretory product of the ovary. So this is the main thing we're going to see here. We'll find a lot of the estrogens that we use may be synthetic versions of this that have pretty similar activity. We also have like estrone and estriol, and that gets converted elsewhere, like in the liver, out in the periphery. But clinically, we're going to mainly focus on the effects of estradiol. Interestingly enough, again, I like to point out animal or plant sources of medications where appropriate, and we actually find that equine estrogens, things like equilinine and equilin, which come from horse sources, actually used to be used for replacement of these hormones, right? So you could actually use something called Premarin, which stands for pregnant mare urine. They used to capture that and then purify it and then give that to patients, right? It was probably smart to call it Premarin because you wouldn't want to tell your patients, hey, BTW, this comes from a pregnant horse, not ideal, but back in the wee olden times, you did what you had to do. Nowadays it's all synthetic, so you don't have to worry about that so much. So they're still premium products, but I think no horses are used in the manufacture of those products there, which is probably good. Anyway, so what you can see here from the various phases, you will have precursor molecules that are being formed here, and then you can see sort of there's a common product here, androstenedione, and what's interesting is that a lot of these hormones are all sort of related to one another, and so that's important for a lot of the side effects you'll run into, because the body is able to, in some cases, convert products between one another, especially if you start to kind of affect the enzymes. You can find that certain products may have cross-reactivity with different receptors. So for instance, just because something is a progesterone-like molecule doesn't mean it just affects progestin receptors. It can affect other receptors as well, as we'll see here. But point being is that you can have this androstenedione, which can be converted into testosterone. And testosterone will be a precursor to forming estradiol. You can see here the enzyme aromatase is really important for this. So aromatase will convert this over into estradiol, which we mentioned is that main product that we're concerned with. You can see how it can then get converted into things like estrone and estriol and all of that. So consider, if you will, what would happen if you, say, inhibited the aromatase enzyme, right? If you had someone who normally would convert this testosterone into estradiol, what would happen if I, inhibited this enzyme? Well, I'd have less estradiol, which may be good in some cases. Say, for instance, if someone had breast cancer that was being stimulated by the estradiol, but then I would have elevated levels of testosterone because it couldn't get converted over, right? So that's why you can see in some of these cases some of the side effects that come about from these medications. And again, this is why I always talk about I'd rather you be able to like sort of intuit why things happen rather than just memorize that things happen. So if you can say, okay, well, if I give someone an aromatase inhibitor, it's going to cause testosterone-like effects. If you understand why that is, it's easier to remember in my mind than if you just memorize what the side effects are of aromatase inhibitors. So hopefully that makes some sense. But anyway, we have a lot of different synthetic estrogens that we will use in patients here. Ethinyl estradiol is probably far and away the most common one you're going to run into in terms of either like hormone replacement therapy or like an oral contraceptives and things like that. But certainly there are others, things like estradiol, acipionate, valerate, etc. You'll find lots of varieties that are out there. There's the products that are called conjugated estrogens. It's basically just a mixture of different compounds there. And again, you're not going to have to draw these out or anything, but just be able to recognize if something is an estrogen-like product, and it should be relatively easy if you look at the names there. It's pretty straightforward. So what are their pharmacokinetics? Basically, they estrogens in particular tend to be pretty highly protein bound. Again, if you were to give estradiol, that can be converted in the liver to estrone and estriol, and that will happen like in the fat tissue and elsewhere in the periphery as well. Big component here that I want to focus on is the fact that it's hepatically metabolized. So two big things that come about from this. One is that you'll find that conjugated metabolites, so it basically gets conjugated in the liver, so something gets added onto it, and then it gets excreted in the bile. Okay, so once that happens, then it actually gets hydrolyzed in the intestine, usually via the colonic bacteria will then cleave that conjugated product, and then you'll have just regular old estradiol again, and you can reabsorb that. That's part of that enterohepatic recycling that occurs there. The benefit to that is that it extends the half-life of the estrogen, right? So levels stay higher for longer because you're basically recycling the stuff that you're metabolizing and reabsorbing it. So that can be a good thing. We'll see there's ways to sort of disrupt that system as well, and that can be problematic in some cases there. But we'll also find that you're going to see that as it gets metabolized through the liver, that it will have effects there in the liver. There are estrogen receptors in the liver, and you can see that will cause a lot of the hepatic effects. And so, and this is typically for like orally administered or say like, parenterally administered estrogen products. You'll see a lot of hepatic effects because it gets metabolized through the liver. Now, this can actually be avoided by giving other routes. And so injection will bypass some of this, but I want to more focus on things like vaginally administered or transdermally administered estrogen products that will actually have fewer hepatic effects. Specifically, the vaginally administered estrogen, you're going to see that it has not a ton of systemic absorption, at least comparatively to something like transdermal or orally administered estrogens, but it will have a lot of local effects. And if you're having a local problem in the vagina, then you just want the drugs to work there, right? So that's going to be one of the benefits and some of the things we'll look at when you're getting into the various dosage forms that we can use for these products here. So how do they work specifically? Well, that's basically they work like any hormone does, just like corticosteroids work, just like testosterone works. It will get down into the cells. So it'll go down to the nucleus, and you'll have estrogen receptors that will be responsive to the estrogen, that will change things like gene transcription. It will upregulate certain products, will downregulate other products. It will affect cell growth, maybe stimulating growth in some tissues. All those effects, and you'll see that depending on the tissue, you're going to get different effects, right? Because not every estrogen receptor is created equally. Some will have some modifications to them depending on the tissue, and that can actually be used to our benefit when we get into selective estrogen receptor modulators. That's important that they're selective, because what a estrogen receptor in the breast tissue does is different than what it will do in the bone, for instance. So we'll get into some of those details here in a little bit. You probably can intuit some of these changes that will happen, just kind of what we've talked about before and what you've gotten in Clin Med and all of that, right? So they will basically bind to those receptors there, and then will change transcription of various genes, proteins, etc. And as I mentioned, you'll find that the interaction there is going to be responsible for lots of effects, right? So whether or not we're going to get a lot of hepatic effects, bone effects, breast effects, vaginal effects, etc., we'll get into those specifically here. So what do we expect to see from the effects of estrogen? Well, certainly we can see things like female growth and sexual maturation, right? So certainly around like puberty, you get a lot of development of things like the vagina and uterus and other secondary sex characteristics. You will see things like the epiphyseal, basically the growth plates closing earlier on, and so that'll happen during puberty. In things like fat distribution, hair growth, all those typical things that you would expect to see with typical maturation of a female patient during puberty, right? We'll also see that with the endometrial effects, this is important as well, that estrogen is going to have a stimulatory effect to develop the endometrial lining. And so it's important to counterbalance that, or to, I guess, balance out the effects of that with progesterone, because progesterone normally helps to encourages regular bleeding and shedding of the endometrial lining. And we're going to find that if you have sort of just continuous exposure to estrogen alone, you're going to get some issues, because that's going to constantly stimulate the endometrial lining. It's going to cause hyperplasia, which can eventually lead to cancer risk, and you can see things like abnormal bleeding. So that's why you frequently see oral contraceptives are not just single products, or combo products. They'll have an estrogen typically plus a progestin. You rarely will find estrogens used by themselves unless certain conditions are met. Now we'll talk about what those are here in just a little bit. Basically, it's going to hinge on whether your patient has a uterus or not. Because if they don't have any endometrial lining to stimulate, then this is going to be less of an issue, as we'll see. Other metabolic effects we're going to see here as well include things like effects on the skin. Blood vessels can be affected by estrogen. You can really see that it affects the entire body in a lot of ways. Decreasing bone resorption is also another important feature here. It will basically stimulate the apoptosis of the osteoclast. You'll see that will antagonize parathyroid hormone. So this is why frequently for, say, postmenopausal patients, we will give estrogens to replace what they're missing, because we do know that their risk for osteoporosis is increased if they're not producing their own estrogen anymore. You'll see adipose tissue development be stimulated here. You may have some effects on serum proteins due to the liver effects, and then some effects on cholesterol as well. So typically you'll see reductions in total cholesterol. You may see some increased triglycerides, and HDL should be a little bit increased as well, just due to these effects alone. Clinically, really important here is the coagulation effects. And this is why I mentioned before with like VTE and PEs and things like that. I always think about like the young lady who's on birth control who is smoking, right? That's like a classic sort of like PE presentation. That's some things you'll find in their history because one, smoking increases your risk for PEs, and then the estrogen effects here really ramp up production of a lot of clotting factors. You'll have increased factors being made, decreased antithrombin 3, and so that's just a perfect recipe for developing these clots here. Now, again, obviously it's not for everyone, but that is something that you would ask about, certainly, if someone presented with a PE. If you ask about their medication list, this would be one of those big kind of buzzwords. If you heard that, you'd be, that should be something on your radar, basically. And then other things you can see, there's some mood and libido effects. And then you can cause some fluid retention. Why would that happen? Recall though that these are not completely selective just for estrogen receptors. You can see some side effects, and we'll talk about, and this is more so important for the progesterones, but we'll see that it can have effects on the mineralocorticoid receptors, right? Things that aldosterone normally affects. You can have some effects here, which can cause fluid retention. And I'll dive into more detail on that when we get to talking about progesterone and other progestins. So what do we use these for? We can do them for primary hypogonadism. So if you had someone who had some development issues, interestingly enough, I remember one time when I was volunteering in pharmacy school, we actually went to the School for the Deaf and Blind in, I think that's still the name of it, but we went to the that school in St. Augustine, who famously Ray Charles went to that school. If you guys didn't know that. And I believe it was Ray Charles. Yeah, I think so. But we went there, and actually really interesting is that a lot of those kids these kids were coming in for from summer break, and we were checking in all their medications, making sure that they were stored right, making sure their medication lists are up to date. And interestingly enough, a lot of those kids who were blind, it was as a result of some sort of tumor that they had developed, and that was resected, and it affected the optic nerve, unfortunately. But a lot of times they had pituitary deficiencies because they had a pituitary tumor that was removed, basically. And so a lot of them were on these growth hormones and things like that to replace what they were missing because their pituitary gland was no longer present. And so a lot of them were on things like testosterone. People are on estrogens, growth hormones, etc. And so really kind of an interesting thing that really kind of keyed that into my mind of that whole negative feedback loop you see there between the hypothalamus and pituitary gland, all of that stuff. So really, really interesting. Really fun group of kids too. But anyway, so what we'll see here is that you can start these when patients, would normally develop puberty, right? So you can begin them at, like, say, 11 to 13 years of age, typically when that would occur. And again, this is to help replace what they are missing, typically. And you can give them the normal cycles of estrogens that they would normally receive anyway if they had a normal functioning system here. So you could say give them days 1 through 21, and then normally when you see that big drop off in estrogen levels based on that graph we saw before, then they would abstain from that. We'll talk about how birth control pills are sort of designed here a little bit later on. And then once they develop their first uterine bleeding, then you add on progestin, right? So that way they get that normal cycle there. You're not getting unimpeded stimulation of the endometrial tissue, which you can see can lead to hyperplasia and cancer risk. Anyway, other things we can do here would be for postmenopausal hormonal therapy. So this is going to be for, when you hear hormonal replacement therapy or HRT, this is what we're using this for, basically. So once you have patients who have had a drop off in their own production of estrogen, you can replace that, because we'll see that when you have that lack of estrogen, you can develop a lot of sort of classic symptoms here. So things like vasomotor symptoms. So when you hear about things like hot flashes, that's what they're talking about there. They get very hot and flushed. I liked how my mom went through that. She talked about them as being, she called them her power surges. I liked the positive spin on that. But you'll see either abnormal bleeding or loss of menstrual periods, sleep disturbances. You can see a lot of genital atrophy, which can lead to things like dyspareunia, vaginal irritation, dryness, itching, etc. You're also going to find, maybe more importantly from a sort of long-term standpoint, would be the osteoporosis and acceleration of that bone loss, which can lead to fractures. And then certainly changes in lipids, which can lead to atherosclerotic changes, right? So if their HDL is going down, if their total cholesterol is going up, things like that. And And so for a while, they actually, interestingly enough, thought that estrogens were cardioprotective, like so you could basically use that to try to prevent heart attacks. However, there was a really big study done back in the day, probably I don't know, probably 15, 20 years ago at this point, called the Women's Health Initiative, might be longer than that. Where they were kind of comparing women who got hormone replacement therapy versus those that didn't. And again, you're counterbalancing the fact that, yeah, it helps out with cholesterol, but it also puts you at higher risk for clotting due to the effects on the liver. And they found that, there's really no benefit to that. So you won't do it for that purpose specifically, but that could be a side benefit you get with supplying extra estrogen. Someone said, I know a lot of girls who will take their oral contraceptives and never take the sugar pill. They'll just start a new pack the minute they finish the last so they never have to bleed. Can that cause bad effects on fertility later on? It's a great question. We'll get to that in just a little bit. Just you wait, avid viewer. We'll get to that. So as I mentioned with postmenopausal therapy, or the HRT, hormone replacement therapy, we have to kind of balance the risk on the cardiovascular side of things, the osteoporosis side of things, risk for breast cancer, because you'll see the estrogen stimulation on breast tissue will potentially cause hyperplasia and cancer risk, endometrial cancer risk, and all of that. So we typically find that if you can bypass the liver as best as possible, so avoiding oral dosage forms, that lowers the risk. You'll find less effects on the liver. There still may be some, but lesser so if you do things like transdermal estrogens, or if you can just apply it, if they're just having vaginal symptoms, and just use a vaginal estrogen. And that can be one viable way to go there, because you'll have less systemic effects and just local effects there. Transdermal effects should have systemic effects as well, because you're absorbing it from the skin into the systemic circulation there. So it's kind of the difference between those two. Vaginally administered estrogens just work in the vagina for the most part. Transdermal still works systemically, but it bypasses the liver to see lesser of the risk for things like clotting and whatnot. So, and for these patients here, again, you're just replacing what they're missing. So when you're comparing the relative doses between say for instance, for birth control purposes, so like for suppression of ovulation, those doses are much higher because we're trying to shut that system down, versus here we're just trying to replace what they're missing. So if you can use the lowest dose possible, try to manage whatever symptoms they're finding most troublesome, that's going to be beneficial for these patients here. Now, one thing to note is that patients with a history of like a hysterectomy can get the estrogens just by themselves. If they don't have, a uterus, or you don't have endometrial tissue to stimulate, then they can get estrogen by themselves. If they have an intact uterus, then they need to get a progestin product along with that, because again, unimpeded estrogen effects on the endometrial tissue can lead to that cancer risk, and that's what we want to avoid. So if they have an intact uterus, give them a progestin along with the estrogen. If they don't, then you can just use estrogen by itself. So that's one of the big caveats you'll see with that. And someone was asking, what's the purpose of sugar pills? Why can't patients just not take anything? That's another good question. We'll get into that in just a moment. Some of you may already know that answer, but I'll talk about it. I always love this lecture because I always get like a lot of really good questions, most of which I don't know the answers to, but some that I do. And so I talk about this stuff. I also think this is like pretty wild, kind of affecting the hormonal system, and just kind of all the really interesting effects you can get from that, because it is so widespread, in a lot of ways. But anyway, so other clinical uses we can see here, osteoporosis prevention and treatment. So that can be a viable way in addition to calcium and vitamin D. And remember that like you can do all the osteoporosis treatment you want, and give them all the estrogen you want, you can give them all the bisphosphonates you want, but if you don't give them the calcium, and they don't have the vitamin D there, it's not going to do you any good. So you have to get vitamin D and calcium intake in, otherwise your other therapies are going to be limited in how effective they can be there, right? And again, think about like Caucasian patients, smokers, inactive, low calcium intake, those are the highest risk patients. So those are the ones you have to have the biggest interventions, and you'll get the most benefit if you can correct some of those issues there. And as I mentioned, topical preparations, when I say topical, I'm not talking about like the transdermal patches. I'm more talking about topically, like administered to the vagina itself. So intravaginal administration may be a better way to say that, but you could use topical as well. You'll see that. That can be for atropic. I don't know what atropic. I don't know if that's the right word, but atrophic sounds more correct. Atrophic vaginitis alone. So if they're having like dyspareunia, if they're having itchiness, if they're having dryness, irritation, whatever the case may be, you can just use topically administered estrogen products, and that will, again, work locally and mitigate a lot of the systemic effects you'll see there, right? So other uses for estrogens, we can use it for ovulation suppression. Again, not every person who is on birth control is using it for prevention of pregnancies, right? Not every person who's on birth control is sexually active. I think it's a misnomer. A lot of patients or a lot of like family members and things like that will have that. It could be a point of clarification for them. Oh, good. Someone answered that question for me, which is fantastic, but we'll get to that in a moment. And again, you can see this for patients with like dysmenorrhea, or they have like really bad like bleeding disorders and things like that as a result of their normal cycle. You can try to suppress that with estrogen products here. And interestingly enough, you can also see that, as I mentioned before, testosterone is a precursor to estrogen, right? So you can find that some patients may have a harder time, or maybe due to overproduction, have high testosterone levels that they're not converting all over into estrogen. So as a way to suppress that production of testosterone, we can use exogenous estrogen to shut down that system, right? So LH and FSH is stimulating production of that testosterone for that patient there. They can develop things like hirsutism and amenorrhea and fertility issues. By giving estrogen to suppress that system, you're going to find that that will decrease testosterone levels, right? And again, this could be useful as well for patients who, one thing I was starting to think more so about is things like transgender patients, right? When they are on receiving hormone replacement therapy, part of it is to suppress testosterone production, not just to give them estrogens for the feminizing effects, but to also suppress their own production of testosterone to limit masculinizing effects of that. So some other things too we'll see in terms of adverse effects. You can get uterine bleeding. This is as a result of the positive stimulation there on the endometrial tissue. Really important, and I'll mention this later on, is that any abnormal uterine bleeding, you gotta figure that out before you start estrogen products. It could be simple, dysmenorrhea. It could be, a lot of simple things, but you want to rule out the scary stuff. So particularly cancer. So make sure they don't have endometrial cancers before starting out on estrogen product there. And typically, if you can use the smallest dose possible, that will help to limit that to some degree there. And again, you can give it cyclically, right? So you can give it to sort of mimic the normal patterns that these patients would be releasing it. So you'd have sort of a gradual ramp up through the first 3 weeks, and then they would have a withdrawal period for the last 7 days or so, and then you can start the process all over again. And to limit this as well, especially if they have an intact uterus, to prevent uterine bleeding, you would give this with a progestin. Okay, so that helps to limit that, because again, the progestin sort of helps to kind of curb that stimulation of the endometrial tissue that estrogen does there. Someone's saying, unrelated to the topic, but if someone takes bisphosphonate to prevent osteoporosis without being at risk for osteoporosis, can they get bone overgrowth? Not that I'm aware of. I don't know if that's really an issue, but I think it'd be rare that you'd run into that problem. Yeah, I'm not aware of, but I can see that more so with something like teriparatide. Remember, that was a big risk with that one, like a black box warning for that of causing bone cancer, but I don't know that that's a problem with bisphosphonates as far as I know. Because again, it's just mimicking that pyrophosphate, not so much directly stimulating bone growth like the teriparatide does, but interesting question. Anyway, other things with estrogens, you can see potential cancer risk. So we think about things like breast cancer risk with prolonged use. In this case here, where progestins do inhibit the endometrial cancer risk, because they help to stop that overgrowth due to the estrogens, it does not affect breast cancer risk. The progestins do not. Some ways to avoid this include use of the SERMs, or the selective estrogen receptor modulators. We'll talk about those later, but that's like tamoxifen, raloxifene. Those are more for like high risk patients that have like that history of breast cancer in their family. For the endometrial carcinoma, that's why we give progestin, in order to help limit that. And we'll talk about those a little bit later on. And then some risk of, particularly this one, risk of adenocarcinoma. This is really interesting. This is something that was discovered when we talk about things like teratogenic effects. There was this product that used to be used as a synthetic estrogen called diethylstilbestrol, or and so they used to use it as synthetic estrogen. And what was wild is that these moms would use the estrogen, they would then have a child, and then that child would go on to develop cancer like decades later. And so the fact that they were able to identify this based off of good sort of doing things like case control studies and things like that, they were able to find that the maternal use of this medication actually led to cancer in the children. So even though the teratogenic effect, you think about things like birth defects that come out of the womb, some of this stuff may take years in order to develop. So pretty wild that they were able to actually discover that, and that's a product we actually don't use anymore. But so other things you're going to see here, nausea, vomiting, certainly more so with the oral products, more than the like transdermal or vaginally administered ones. Breast tenderness due to stimulation of the breast tissue, makes sense there. Hyperpigmentation can happen. With migraines, some people will find that estrogens help their migraines. Some people find that it worsens it. Depends. Cholestasis makes sense because it's undergoing biliary excretion. So you can see that could be worse in there due to all those conjugated products being released there. And then hypertension is more so related to fluid retention issues. So that's something that you can monitor for. Brian is asking, how does progesterone prevent endometrial carcinoma, or is it that the treatment for it? It's not the treatment for it. It's just that by giving progesterone, that helps to curb the stimulatory effects of estrogen on the endometrial tissue. So basically, if you go back to that picture, someone slide 70, but if you go back to this, if you kind of consider the endometrial tissue, the estrogen early on, you can see here as it lines up on the graph, is stimulating this tissue here. The progesterone sort of is going to be that trigger to cause that sloughing to occur. So it basically helps to curb that growth, and then it will help to stimulate the eventual sloughing of that tissue, and that leads to menses. So progesterone will have a natural inhibitory effect on the growth of the endometrial tissue. Okay. Just estrogen alone will cause this just to continue to grow and grow. Some of that tissue will die off and cause bleeding, but the cancer risk is there, so we give progesterone to help curb that. So hope that makes sense. All right. So again, use the lowest dose possible, especially if you're using it for like hormonal replacement therapy. So whatever is going to work for their particular symptoms, that's going to be most beneficial there. In terms of, let's see, someone had a question. So someone's asking, why would pregnant women be taking estrogen, diethylstilbestrol? I've not researched all of that. I'm not sure if they were using it maybe before the pregnancy, or if I can't imagine they're using it during. I've not looked too far into it. I just know that there's that link between the two there. But yeah, that's why we don't use it anymore, is because we know that cancer risk is present there. So yeah, just more of a historical point than anything else. You're unlikely to encounter a patient nowadays that would have been exposed to that potentially, as far as I know. Anyway, so contraindications, if they have any sort of like estrogen dependent neoplasm, like breast cancer, endometrial cancer, cervical cancer, etc. Any undiagnosed genital bleeding, that's the other big thing I mentioned there, is make sure you rule out all the scary stuff before you just start treating a patient with estrogen for bleeding issues, right? Liver disease, thromboembolic disorders, and heavy smokers. And again, these two are kind of linked here between the clotting risk and the smoking there. So these would be contraindications. So switching gears here and talking about progesterone or progestins in general, and progesterone being sort of the most common one that we're going to be seeing here, most important one. Again, this is another precursor molecule to a lot of estrogens, androgens, and also adrenocortical steroids like aldosterone. This will be important because you're going to see a lot of various effects for these for progestins, and you'll find that some of them will have more effects at things like androgen receptors than others. Some will have more effects at mineralocorticoid receptors than others, and so we'll get into some of the side effects we can see there as well. Typically, when you're looking at like different forms of birth control, and I'll post up a PDF that may be a few years out of date, but it just shows you just the huge number of different types of birth controls that are out there. And we'll talk about the different varieties, but a lot of times the different varieties are going to be based off of the different progestins they use, because you can find different side effect profiles for each of them. So when patients are switching between birth controls, frequently they're trying to find the progestin that's going to work best for them from a side effect standpoint. So we'll get into that in just a little bit later on. And again, as I meant, that's kind of all going into that point that there's a high variability in the physiologic effects between agents, more so than the estrogen. Estrogens are pretty consistent in terms of them really affecting primarily the estrogen receptor, and that's pretty much it. Maybe a little bit of mineralocorticoid effects, but the progestins are going to be all over the place, as we'll see here in just a little bit. So this is a historical problem, right? This is what I've been kind of alluding to, is you're going to see effects of the androgen receptor, which is going to be abbreviated AR, and then we'll have also the effects of the mineralocorticoid receptor, MR. So as you might expect, if you agonize or activate the androgen receptors, you're going to get masculinizing effects, right? You're going to see things like maybe changes in their voice. You can see hirsutism. You may have ovarian dysfunction. All of that is related to the androgen effects, the masculinizing effects. And then the mineralocorticoid effects are going to be more so to do with things like blood pressure, edema, fluid retention, that sort of thing there. So, which is not great because, if you can see sometimes that patients may put on some weight when they start one of these progesterone products, and all of that's related to the fluid, right? They're just holding on to more fluid, so that's causing them to gain that weight and a little bit of puffiness and things like that. That may be a reason for them to want to change and go to a different medication, right? Or if they're having excessive androgen effects. So a lot of the ones we have sort of early on were things like norgestrel and levonorgestrel, really had high androgen receptor activity. And again, people may respond differently to it. Not everyone that gets levonorgestrel is going to get a ton of the masculinizing effects. So for some people, this is an okay drug. It's totally fine. For others, it may be problematic enough they want to change it. Things like norethindrone, norgestimate, you can see here various activities here. As we get to later stage ones, we're getting less androgen receptor activity, so probably good from that standpoint. And drospirenone is actually probably a very popular one nowadays, is nice because it actually has anti-mineralocorticoid effects, so it actually causes you to maybe urinate off some extra fluid, and then anti-androgen receptor effects, right? So I see a lot of people who have tried other products that contain things like levonorgestrel. They don't really like it that much, and they'll switch over and then finally get to drospirenone, which is like in Yaz and Yasmin and products like that, and they really like it. So, may not be good for everyone, but I see a lot of people do tend to like that one. So with progesterone, you're going to find that it really doesn't have a ton of kinetic issues like you're going to see with estrogen. Not a ton of liver effects, as you'll see. More so, you're concerned with things like the androgen receptor effects and mineralocorticoid effects and all of that, but not really any effect like on the clotting factors, anything like that. So that's why in some cases, especially for ovarian suppression, you can see that a patient would never be on an estrogen by itself because of that unchecked stimulation of the endometrial tissue, but they could be on a progestin by itself. That's totally fine because you're not going to get the same effects there. So I'll talk more about that in just a little bit. And again, their mechanism is identical to the estrogen receptor, or to the estrogens. It's just that they work on progesterone receptors. Okay, so they're getting down to the nucleus, activating those receptors and causing changes in cell growth, gene transcription, etc. Right. So as I was mentioning, little effects on lipids. You may find they actually have some good effects on glucose because you may have some increased insulin responsiveness, which could be good there. And as I mentioned, it can be competing with aldosterone in the kidneys. And by competing with that, not only can these drugs themselves interact with the mineralocorticoid receptors, which is where aldosterone works, by impairing that ability for aldosterone to bind to those receptors, because if they're occupying it, aldosterone can't do anything. That can kind of disrupt the negative feedback loop and cause more aldosterone to be released, which is again going to hold on to more fluid, which can lead to weight gain and edema and things like that. So, as I mentioned, you then have maturation and secretory changes in endometrium. And it was funny, like when I try to explain the different changes during the menstrual cycle, I liked one analogy that a student had come up with, which was really good, is that, and I think Professor Lack uses this too, so you might have heard this, is that estrogen on the endometrial tissue is like fertilizer, just causes it to grow like crazy. And then, like if you just had like grass growing like crazy, it doesn't look that good. It doesn't mean your lawn looks good just because the grass is growing. You need a lawnmower to kind of help mature it and help to kind of keep everything even. And that's where the progestins come in. They sort of help out with that maturation of the endometrial tissue. So estrogen's like the fertilizer, and then the progestin like the lawnmower that makes everything look nice and neat there. Maybe a bad analogy, but that's how I think about it. And so anyway, as we get into these synthetic agents here, again, you're going to find that they will have, relatively minimal adrenergic or anabolic activity, but we'll see that can vary depending on the synthetic product that we're using there. By getting less androgenic effects, by getting less of the mineralocorticoid effects, again, that helps to reduce side effects overall. So what do we use this for? Again, hormone replacement therapy. So again, if you have, say, a patient who is postmenopausal, who is not producing their own hormones, if they still have an intact uterus, you would give them estrogens plus a progestin, because again, you don't want to have unabated growth of that endometrial tissue, because that can lead to the cancer risk, as I've been saying probably for 1,000 times already. The other big place you'll see this is for long-term ovarian suppression. And again, you can use this by itself, but you would never use an estrogen by itself for suppression of ovarian function, okay? Again, how this is working is by activating receptors up in the pituitary and the hypothalamus. It's saying, hey, we have enough progestin here. We don't need to release GnRH and LH and FSH, so okay, let's go ahead and suppress that. And again, it's not the estrogens and progestins that are causing ovulation to occur, it's the LH and the FSH, right? That's what's actually causing the ovulation to happen there. So if you can decrease production of LH and FSH, then you don't have ovulation occur, and hopefully pregnancy will not happen, right? Anyway, so you can use progestin by itself. So as an example, there's medroxyprogesterone acetate, which is Depo-Provera. That's the Depo shot that most people are referring to. Notice this is not like, there are other Depo drugs we've talked about, like methylprednisolone, for instance, but here we have medroxyprogesterone specifically. And so this is given intramuscularly every 90 days. If you're using progestin-only therapy, there are some problems with that you're going to run into. One of the things that's nice with this, though, is that because it's given every 90 days, you're going to find that compliance is ensured. And most of the failure that comes about from use of contraceptives is generally due to failure of being compliant with the failure is due to non-compliance, I should say. So with this one, basically you're covered for the 90 days. And if they don't come back, it doesn't mean that, on day 91, all of a sudden they're ovulating. It will have a little bit of a lag time to it, to where even if they came in, a couple weeks late, they probably still have enough progestin around to suppress ovulation from occurring. The problem with that is that if you had someone who wanted to become pregnant, this could lead to prolonged anovulation. It could take longer for them to get to a point where they can actually ovulate again. So I tend to find that for patients who are kind of schedule minded or calendar minded in terms of when they want to get pregnant, this may not be a good thing, because they could have that delayed return ovulation and they may not be able to get on the time scale that they're looking for. Not that you can time those things out perfectly, but at least in general terms, this could delay that. So you can see this, being used for other cases here: endometriosis, dysmenorrhea, bleeding disorders. If you could not use an estrogen for whatever reason, maybe they had a previous, VTE while taking an estrogen-based product, you could use progestin by itself. Okay, and again, you'll have a little bit higher failure risk with using progestin-only products, but again, if they can't receive an estrogen, then this is a good alternative. So in terms of adverse effects, you could see changes in blood pressure probably going up as a result of aldosterone-like effects. And again, having androgenic effects, so testosterone-like effects, can actually lower HDL, which is not great. So let's go and just kind of talk about hormone replacement therapy specifically. So we kind of have how we're using, or what these drugs are doing. Let's talk about how we use them specifically for these different conditions here. So let's start with HRT, hormone replacement therapy. So in terms of like FDA approved indications here, here's what you're using these for basically. So if patients are having like vasomotor symptoms, so like hot flashes and sweating and flushing and all of that, that's an okay use for HRT. If they are developing vaginal symptoms like dyspareunia, dryness, things like that, that's good to use as well. And also for prevention of osteoporosis. Those are the FDA approved things. Not that that's the only things you can use them for, but that's what the FDA has given its blessing to, right? So as I mentioned, if the patient has an intact uterus, you want to do estrogen plus progestin, okay? Now, because we're simply replacing what they're missing, we're not really so worried about ovarian suppression. We're not worried about, ovulation suppression. You could just give the drugs every single day. You don't really have to worry about withdrawal periods here. if the patient would like to have more of say like a normal cycle, you could go ahead and give a product that would sort of mimic that. So for instance, you would do something like estrogens on day 1 through 25. The product would then have tablets that would include progestins on day 10 through 14, and then they have drug-free days on say 26 through 30, right? So that could be a way to sort of mimic what a normal cycle would look like. And again, you're just going with the lowest dose possible because we're just trying to treat the symptoms. We're not trying to suppress anything here in terms of how much estrogen effects we're really looking for. Yeah, so someone said, are progestins not a risk factor for VTE? Yeah, not really. They don't have any of those effects on the clotting factor, so that's not a concern there. So if you had a patient who had a history of VTE due to estrogen-containing products, you could switch them to progestin only, like a Depo-Provera, and that would be fine. You could do that by itself. There are other alternatives, which we'll look at in just a little bit, so we'll get into like the IUDs and whatnot, but that is not really a big risk factor there. All right. As I mentioned, you could use estrogen by itself if patients have a history of hysterectomy. Again, that could either be used continuously or cyclically, right? Again, it doesn't really matter at that point there. It just depends on if they want to have more of what they would normally produce as a replacement, or they can just get it continuously. That's totally fine. And you'll find, you could use like low dose oral contraceptives, but again, if you're looking at this, we're just replacing, we're not trying to suppress anything. So if you look at the typical estrogen effects of like OCPs, oral contraceptives, that's usually like 4 to 6 times as much. So again, using an oral contraceptive for HRT is probably too much. You probably don't need that much estrogen activity. Someone said, after long-term suppression therapy, generally how long would it take a patient to regain normal ovulation? So it depends on the product that you're using. So we'll find, and actually, let me talk about that in just a little bit. Once we get to the OCPs, I'll talk about that. Sorry to push your question down, but we'll get to that in just a little bit. I just want to like kind of encapsulate this, and we'll talk about all the contraception stuff. That's usually what people have the most questions about anyway. Anyway, so using oral products is going to undergo the most first pass metabolism, and that's what stimulates those hepatic proteins. That's where you're going to get the clotting factor effects. That's where you're going to get, the changes in lipid profile, etc. And so if I had patients who either had issues in terms of like cholelithiasis, higher risk for VTE, if they had a history of hypertension, you can use transdermal. It will mitigate a lot of those effects because not as much drug. Because again, if you take it orally, everything goes through the liver first. That's where you get the lion's share of those effects. If you do transdermal, then you have less risk for that. Okay. If they are having vaginal symptoms only, then just use intravaginal products, right? You can use things like intravaginal, gels and ointments and things like that. They also have things like rings that have been, probably a bad term, but impregnated with the drug or embedded within the ring is the hormones, and that can release locally, so that we just get local effects to help out with that atrophic vaginitis. But you should have limited systemic effects, not zero, but it should have minimal effects. So someone said, for a patient with hypertension, would a progestin-only pill be better than a combo, and would either carry risks that it really wouldn't be a deciding factor there? So it depends on the progestin that you're using, because some of them could increase blood pressure, right? Because you could see that some of them will have the mineralocorticoid effects that could increase blood pressure. So something like drospirenone would be less likely to do that, but say something like levonorgestrel or something may have a little bit higher risk. I'd monitor for that. I wouldn't say it's contraindicated, but I would at least monitor for it. And again, you're not going to see like huge increases in blood pressure with these products here, but it depends on the patient and how sensitive they are to those effects, right? I'm more worried about the issues in terms of like clotting effects. I'm more worried about things like the cholelithiasis history and things like that, to be honest. So someone said, is the estrogen progestin therapy on slide 81 not oral contraceptives? 81. That was just more so referring to, and so this is more so referring to if you were to use oral contraceptives as hormone replacement therapy. You typically wouldn't do that, even though it would work. It's just way too much. You don't need that much effect that those drugs are carrying. Because again, think about what the purpose is. This is replacement. Oral contraceptives are for suppression of ovarian function. I'm going to take that off. So, I'm going to go through some of the dosage forms. The purpose is not to have you like memorize all of these. Certainly, you should be able to recognize if something is an estrogen based product, if something is a progestin based product. And again, this is, few years old, but most of the products here are the same. This has not been There's not been a ton of revolutionary new products in this space here, so I think this is still pretty accurate. So just to give you an example of these different products and what this would look like. So in this case here, you can see the different products here, either like conjugated estrogens, that's like Premarin based products here. You can see the various dosage forms, and again, you're just using the lowest dose possible, right? Keep in mind, different products are going to have various potencies. Some estrogens are more potent than others, as we'll see here in a little bit if you're like comparing doses. But again, lowest dose possible for HRT purposes here. And if you notice, these can be for just continuous use, right? You could take this every single day for HRT purposes and not really run into any problems, right? They don't have to have a withdrawal period necessarily. It's only if the patient's likes that, or if it kind of fits their side effect profile that they're experiencing, whatever the case may be. But they can do it just continuously. That's fine for the most part. Here is an example of ones where they could do it more. I'm sorry, this is more of a patch based product here. You can see there's lots of different brand names for them. If you work in this population, you'll kind of get a feel for the different products and kind of what you like to use and don't like, etc. These can be good because these can provide continuous effects. So that way if the compliance is an issue, they can do it once a week or maybe twice a week, and that can help out from that standpoint. And the other benefit is it misses a lot of the hepatic effects. So this could be good for some patients. You can do transdermal gels in some cases there, transdermal sprays. There's lots of varieties that are out there for whatever fits your patient's lifestyle the best, right? Here's an example of some vaginal creams that can be used here. So if you notice, just comparing dose to dose, like it looks like this is giving like a huge amount. Like before, you're giving like 0.3 milligrams of estradiol or conjugated estrogens. If you notice here, it's like you're giving 2 to 4 grams, but you're giving a cream, right? And you're giving it locally. So it makes sense that the doses are that much different. Because if you see here, that's grams of the actual cream itself that has a bunch of other stuff in it. It's not just estrogen, pure estrogen. You can see here the active ingredient's still pretty similar in terms of dosing there. Again, this is for local effects. So if they're just having vaginal dryness and irritation, then this is fine. They can just use this by itself, right? Sometimes you may even build in cycles for it. So for instance, here you could do one that's done for 21 days on and then 7 days off, right? You could do that. Again, once you start doing that, this gets a little bit more difficult from a compliance standpoint. As long as patients are good about using a calendar or things like that, that can be useful for remembering when to take it and when not to take it, right? Here's some examples of rings that you could use. So this could provide more long-term use, which is good from compliance standpoint. So for example, the E string or S string, which is basically given 90 days at a time. They would just do this 4 times a year basically, and so that could be good from that standpoint. Again, some of these may have more or less sort of systemic effects, but if you do still have an intact uterus, again, you may want to consider using a progestin along with it, right? So that's still going to be a concern for some of these patients here. Even like vaginal tablets they can use. Some patients will ask, like, what happens if the ring comes out early? They can just put it back in. That's no problem. It's not like it goes bad or something just because it falls out. Here's some examples of what these will look like. Basically, you can see a Premarin cream. You can basically put the ointment or the cream into the applicator, and you can actually see how the dose is sort of listed there, so they kind of know how big of a dose they're giving. Just make sure that they clean this stuff off. You don't want to have like a secondary infection or something because they didn't clean it and it got kind of grody. So that's one thing to consider. Here's an example of the ring. Basically, just place it intravaginally. You can place it against the cervix. That's fine. And again, 90 days at a time, so good from a compliance standpoint. Here would be some examples of combination products here, and you can see some of these are built into where they would do things like estrogens on day 1 through 14, and then you'd have the progestin plus estrogen towards the end of the phase, right? Again, mimicking what the normal cycle might be. Some of them, they're just going to be on continuous combined therapy. They'll just be on both throughout the, continuously, and that's fine too, right? That you don't have to have a withdrawal period for this purpose here specifically. Someone's saying, when using transdermal HRT, is there a specific body part where its effects would be stronger, or is it okay to stick anywhere? Generally, you can stick it anywhere. I think most people probably put it on their arms, but you could really stick that anywhere. Abdomen would be fine. It's just up to the patient. I would typically say try to rotate sites and not place it on the same spot every single time, because you could see, you know, risk for skin breakdown, things like that. So I would just rotate it around. They can go arm to arm. That's totally. Let's see here. Here's some other intermittent products. Again, it just depends on what they want to do. So for this one here, they would do estrogen bites. Oh, it looks like my internet's cutting out. Okay, I'm back. For this one here, you do estrogen for 3 days and then estrogen plus progesterone for 3 days, and it just repeats continuously. So that's why a lot of these products will come like in dose packs, where they will, if you see them, it'll have for each day of the month, they'll have like the pills actually laid out, so patients just go in, pop one out, and that's the one they're taking for that day. And the point is to keep them on this consistent schedule. They don't have to come in those packs, but that's one convenient way to try to keep them on track there. And I'll talk about those placebo pills a little bit later on. So and here be an example of just using a progestin by itself. Again, you probably see better effects for HRT purposes if you can use an estrogen along with that, but for some patients who that's contraindicated, you can just use a progestin by itself. So just some different options there. Again, the purpose is not to have you memorize all these products here. I just want you to see how they're being used, just to kind of demonstrate it and why there's so many different products, because again, you have to find the right dose for your patient, the right cycle for them. If they want a continuous, intermittent, a lot of choices that you have there. And some patients will prefer one versus the other. Some providers will prefer one versus the other. It really just depends on the case there. Okay. Other things we could use for the vasomotor symptoms of menopause, this list actually looks a lot like what you would see being used for neuropathic pain. So things like SSRIs, things like venlafaxine, gabapentin, and even antihypertensives like clonidine can be useful here. The clonidine kind of makes sense because if they're having issues of vasomotor symptoms, by decreasing sympathetic output with clonidine, that can help to limit that. So that could be one thing that's useful there. So just different options. Patient has a history of depression, anxiety, and menopause. They could do both here. That can kind of serve two functions, which is nice. But it's not going to do anything for the vaginal symptoms, right? So from that standpoint, these would not be useful for that. So if I had a test question, I'm thinking about it, where a patient was coming in just for vasomotor symptoms and they have a history of depression, you could try this by itself first and see how it goes. But if they're complaining of vaginal symptoms, then this would not be sufficient. You'd want to have an estrogen product as well, most likely an estrogen product, in order to help treat that, because SSRIs are not going to do anything for it. Okay. So now switching gears and getting into our oral contraceptives here. So as I mentioned, we will find that we'll typically give a combination of estrogen plus progesterone. That's the most common way to do it. And you will find that you can skin this cat a lot of different ways, as you'll find. You can do what we call monophasic, where basically they will come as a constant dosage of estrogen plus progesterone throughout the entire cycle. Okay, so they're getting the same thing the entire time. They could do biphasic, where you're going to see that at one point during the cycle there will be a dose change of at least one of the products. You can find maybe both products or one, but you'll just have one change throughout the month. And then you'll have the triphasic, which is again getting closer to what you would expect to see in a normal cycle, where there will be two dose changes that happen there, probably at week one, at the end of week one, at the end of week two. And then you'll generally find for most of these products here, they'll have the last week is just sugar pills. And so this kind of gets back to the question here. Someone said, I know a lot of girls will take the OC and never take the sugar pill. They'll just continue new packs. So I'll get to that in just a second. But the point of the sugar pills is because it keeps them compliant. Again, the number one failure for these products is non-compliance. It's not that the drugs don't work, although some people with perfect compliance can still have failure of the products. These are not perfect, right? But the whole point is to keep them in that routine of taking something every single day. So that way, if you're like, okay, well, this is the week I don't take anything, and then you forget to go back on the new pack, that can be a problem. So from a birth control sort of standpoint. So for that purpose, that's why they're doing it. So this person here was absolutely right. It's just to keep them compliant with their medication. So very, very observant. Very good point. So, and then as I mentioned, you could just do progesterone by itself. For these type of patients who have an intact uterus, if you think about it using for contraception purposes, so presumably they have childbearing potential, you would never use an estrogen by itself, right? Because that risk of bleeding and endometrial cancer and things like that are no good. But you could use a progestin by itself. That's totally fine. However, you will see higher failure rates just a little bit. But again, not everyone taking oral contraceptives is taking it for birth control purposes. They could be doing it for, suppression of testosterone production because they're having hyperandrogenic effects from that. They could be using it, for feminizing effects because they're transgendered, for instance. Like, so there's a lot of reasons why people may be taking this other than just birth control. And that's something that if you have parents who like don't want their children to start it, for instance, that could be a concern. They're like, oh, well, they're just going to go and have sex. And it's like, well, not necessarily, right? So it's a good education point you can have with your patients there, or their families as it may be. But anyway, so again, their mechanism here, Allison said I had a male friend in high school who said he was taking it for severe acne. Yeah, so again, if the acne is being stimulated due to excessive testosterone, this would help with that because it's going to basically shut down function. So that's a great segue here into the mechanism. Oh, well, yeah, so Shelby had cramps that were so bad. Right, so again, that can really help to suppress that as well. So lots of reasons for it. But by giving this, it's going to inhibit that feedback loop, basically. It will activate the negative feedback loop where it will shut down release of GnRH and LH and FSH. And so if you don't have that, then you're not going to get development of the ovarian, development of the follicle. You don't get all the all the cramping that goes along with that. It helps to minimize that to a big degree there. Or in the case of acne, it would shut down testosterone production, right? Or at least to some degree. It's not going to completely shut it down, but it would help out in those cases there. Okay. Anyway, so looking here, also the other benefit to this, other than just shutting down that negative feedback loop or activating the negative feedback loop, I should say, is it also, I like to think about, it's kind of funny to think about, like it makes it a very inhospitable environment for the sperm to actually cause implantation to occur. So I was kind of think about just like making I don't know the apartment less friendly, I guess, for the sperm. He wants to is not going to implant as easily, but you'll do things like change in cervical mucus. The uterine endometrium will not develop the same way. You'll have less motility and secretion from the uterine tube. So all of that, in addition to the fact that you'll have ovarian suppression, helps to make it very unlikely or more unlikely that conception will actually happen. Okay, or if it does happen, the implantation of the egg, the fertilized egg will happen there. So yeah, it was, and Kelly's saying it helps out with regulation of abnormal cycles. Yes, because you're setting the cycle for them. That'll be a good point here in just a little bit when I talk about ways we can schedule things in terms of that. So thing here though is that progestin, while giving progestins will also make the environment very inhospitable for conception to occur, it doesn't necessarily inhibit ovulation, right? So that's why you see a little bit higher failure rate with progestin-only products than estrogen and progestin products. Okay, so there are some downsides to using progestin only, but again, if they have a contraindication to it, or if you want to use something like a Depo-Provera shot or something like that, you take the risk with the benefits, right? So, as I mentioned here, for the ovarian effects, you're going to depress that function, so they should be smaller during therapy, right? And so you'll find that also most patients will return to normal ovulation fairly quick once they stop it. Not everyone, but you'll find they'll go back to normal patterns. Most patients will ovulate during that first cycle, about 3/4 of them, and then by the third, most patients will have, right? Keep in mind though, if they're on something like a Depo shot, like that can be months before they go back to normal ovulation, because that drug, it's not good. On day 91, it's just gone. There's still residual levels there that could inhibit ovulation, right? Again, some people may remain amenorrheic for several years. That's rare, but could occur there. Okay. Other things we'll see with the uterus, you're going to get hypertrophy here. It will get kind of thicker, less copious mucus. So again, that's helping with that environment to prevent conception from actually happening, right? Impedes the travel of the sperm to get to the egg there. Other physiologic effects you can see include things like enlargement of the breast. You'll find that it suppresses lactation, right? So you'll find there's kind of a counterbalance here with prolactin, but it will suppress lactation. And then the hematologic effects. Again, this is mainly just the estrogen doing this. So estrogen in the liver, especially with the oral products, because that all has the most first pass, will increase those factors there. So again, if they have that high risk, then you probably want to skip the estrogen-based products, especially the oral ones. As I mentioned, you can have hyperpigmentation here, especially with exposure to ultraviolet light. They have more dark complexions that can cause that to occur there. And then, as I mentioned, and the acne thing is kind of interesting because some patients, you'll find that acne is improved while on oral contraceptives. For some people, the progestin effects, if it's particularly strong at the androgen receptor, it can actually worsen acne. So you may need to play around with the progestin to kind of figure out which one works best for your patient. Not everyone's going to respond well to the same product there. I wish it was cut and dry like that, but you kind of have to play around with it, which is why there's so many different products out there. It's really gobstopping, a number of different ones. So anyway, so if we were looking at the clinical uses, contraception is probably the thing most people think of because they're called oral contraceptives for the most part. And you're going to see here that the risk for conception is very small with perfect use. Now, again, people are not perfect, so nobody is perfect, as it turns out. So people may not be completely compliant. But if someone was to be on a combination product and they took it perfectly, if you were to look at 100 years, so either one woman for 100 years, not that they'd be childbearing for all that time, or if you looked at 100 women for 1 year, the general pregnancy rate would be between 5 and 12 for that 100 woman years, right? If perfect use was happening, there'd be closer to like 1, right? I don't know how you have like half of a conception, but closer to 1, right? So you will find though that a lot of reasons why this may fail. So it could be due to non-compliance, sure, but it could also be due to things like other medications, right? So for instance, if people are taking a drug that induces metabolism of the estrogen, so like phenytoin, as we mentioned there, any enzyme inducer is going to lead to more metabolism of the estrogen. It will decrease the half-life, and that could lead to ovulation occurring. Also, if you have anything that will interfere with the enterohepatic recycling of the medication. So that's why things like severe diarrhea or something may actually impair the cycle, and you may have lower estrogen levels as a result of that. So little things like that. And we'll talk about some other examples here in a moment. Let's see. Someone said... I think I'm back. You guys hear and or see me? All right, sorry about that. My internet decided to go haywire there. Apologize. Anyway, so I think, oh, thank you. I'm back. Yeah. Phoebe got to the Wi-Fi. She's a wild child. I always equate her to, if she was a Muppet, she'd be Animal. So that's a reasonable thought to have there. Anyway, so someone was saying, if the doses are too low, could fertility occur? Yeah, possibly, right? And that's why, especially if you're using a progestin only product, that is a risk, right? You can see that happen because you don't get the additional estrogen effect. Primarily though, you're kind of taking a shotgun approach to this. You're giving so much estrogen that you're really suppressing the ovarian function, so that's less likely. But we'll look at some of the different doses that we'll see here in just a little bit when I give you some of the examples. Okay, anyway, here we go. But as I mentioned, so other effects here. Thank you, Brian. I really appreciate you're missing me. You'll get to see me this afternoon as well. That's great. Yeah, old coworker got pregnant twice on birth control. You should ask about her compliance. Maybe she wasn't complying with it, or she was on an enzyme inducer. Who knows? You don't want to blame the patient, but you should investigate, see if other stuff is going on there. But anyway, other uses for this would be things like endometriosis. So you'll find that, and again, I'm getting a new Wi-Fi card for my PC up here in the office, so I'm hoping that'll fix all my issues here. But she was compliant though. They tell you they're compliant. That's the thing. Patients always tell you they're compliant, but they may not always be the case. Anyway, other things we could use this for include things like endometriosis. So we'll find that the estrogen alone may just be sufficient to alleviate the pain, but again, they still have an intact uterus because they're having endometriosis. You need the progestin there. In those cases there, if you're not really worried about them becoming pregnant, you just use the lowest dose possible, right? And so just to see how it's kind of working with their symptoms. If it's working well, then you can kind of scale down the dose if need be. In terms of adverse effects, and again, there's other uses. I'm just listing a few of them on there. So if you see people on for other purposes, then yeah, it's probably makes that sense. Anyway, other things we're going to see here in terms of side effects are going to be things like the mastalgia that has to do with the breast tissue stimulation. They can have breakthrough bleeding. You can actually find what's interesting is that the bleeding risk with this may be due to too much estrogen in some cases, because you're getting kind of too much development of that endometrial tissue. So we can fix that either by using smaller doses of the estrogen or by using progestins with more androgenic effects can kind of help out with that. Progesterone with more androgenic effects will cause more edema, things like that. But we'll talk about different ways we can manage the bleeding here in just a few minutes. As I mentioned, headaches. Some people will get headaches, some people won't. Again, this is very much like a patient-to-patient basis. Some people make their migraines worse, some people better. You just have to try it and see what's going to work for them, right? And then for some patients, what's interesting here too is that when they go through their birth control pack and they get through days 1 through 21 and they get to that withdrawal period, they should have withdrawal bleeding. Most of the time they should. But some people may fail to have that. And so that can be distressing to them because they may be concerned about, for instance, having a pregnancy having occurred there. If that is problematic to them, even though they're not pregnant, you can try other products and see if something works better for them, right? As I mentioned, you're going to find breakthrough bleeding tends to be more likely with just progestin by itself. So if they're just taking a progestin-only product, if you hear like the mini pills, that's typically progestin only. You'll find that more likely. And then also in low-dose preparations, you're more likely to get that problem as well. Some people feel like by using the bi and triphasic products, you will get less bleeding or less breakthrough bleeding, because it can happen in certain parts of the month, maybe at the beginning or towards the end, which we'll talk about a little bit more in a few moments. But by using the tri and biphasic products, you can get less bleeding without having to give them more hormone, because it's kind of modifying how they're getting it throughout the month. So I'll show you some examples of that in a little bit. And then weight gain, this can happen more so with progestins that have more androgenic effects or more of the mineralocorticoid effects. So by switching them to a different product that can help out with that, that's usually the most common thing you'll do for those patients. Dieting can also help out with this, but it's more of a fluid issue in a lot of cases. So really switching the progestin is probably the biggest thing they can do there. Let's see, someone had a question. I thought you'd want to use both estrogen and progestin. Is endometriosis a situation where you can only use estrogen? No, so you'd find that even low doses of estrogen can help out with that, but you have to have the progestin on board too, right? So that's the caveat there. You don't want to use it by itself, but by the fact that estrogen could do it by itself, you can use relatively low doses. So you scale back and see what they kind of tolerate, right? Because again, we're not trying to. None of this stuff is like life-threatening, so you have time to work with this and kind of adjust it as time goes on, right? Providers used to tell me that OCP's nausea effects would go away after 2 to 3 months of consistently taking the combo pill. Do you know why that is? Some things you just get tolerant to over time. You'll find that they may fall into a schedule where if they take it with meals, it helps out, and so maybe they'll just start taking it with breakfast or lunch or wherever they take it. There's nothing physiologically that's really happening more so than you're just kind of getting used to it, I would say. So that's probably just them trying to tell you to take it consistently and not miss any pills there. Okay, so I think I addressed this other question here. It's after long-term suppression therapy, how long would it take a patient to regain normal ovulation? Like I said, for most estrogen progestin combos, it should be right away in a lot of cases, if not within a few cycles. For progestin-only products, it may take longer, so that's going to be delayed for those cases there. Okay. So let's see what else. Acne. Yeah, so with acne, this is more likely to occur with more androgen-like progestins, so like levonorgestrel, things like that. And again, for some people, the estrogens may improve their acne by maybe shutting down androgen production, like testosterone, due to suppressing the pituitary gland. So again, it's very individualized in terms of how it's going to work for them. Let's see. I love those questions. Someone said, can you explain what causes withdrawal bleeding to occur? Yeah, so just like your normal cycle, if you were to look at that graph there, what normally causes menstrual bleeding to occur is you're getting a sudden decrease in your estrogen and progesterone levels, and that stimulates that sloughing off of the tissue. Basically it says, okay, no pregnancy happened here. We don't need all this extra tissue. Let's just get rid of it. And that's what causes the bleeding to occur there. So that is something you'd expect to see. You'd normally be looking for with, again, a normal menstrual cycle, or for patients who are getting to the end of their cycle for, into that 21 days, that last week there should be when you get the withdrawal bleeding actually happening. When they're just taking sugar pills, that's when the bleeding should be happening there. But I'll talk more about scheduling and all of that here in just a few moments. Someone said this might be a dumb question. I doubt that. No dumb questions. But if a patient is on a birth control that is a 3-month supply and have a period every 3 months, does this help if the patient is concerned with fertility in the future, since they are not shedding an egg every month? Not that I'm aware of. I'm not aware of any evidence that says that they're only getting withdrawal bleeding, every, say 4 times a year, that this is going to cause an issue. But I don't know that it necessarily causes any delay in return to ovulation either by being on long-term suppression. But I'll mention that in a few moments when I get to the different products. So hirsutism, again, this is more of an androgenic effect. So this is something where if you switch to progesterone, this can help out. You'll find for some people, they can have uterine dilation, kind of similar to the changes you see in pregnancy. So this is why UTIs and things like that may be a little bit more likely. You want to watch out for that. And those vaginal infections tend to be a little bit more common, maybe more difficult to treat in those cases there. So one thing to look for. And again, in terms of like amenorrhea, patients with, are more likely to, if they had abnormal bleeding beforehand, they're probably more likely to have irregularities during treatment as well. Or I should say, if they have menstrual irregularities beforehand, more likely during. Additionally, also look out for things like prolactinomas and things like that may also be kind of clouding the picture there. It could be kind of multifactorial, so you may want to look out for that. The severe thing, though, is the venous thromboembolism. You're going to see your risk is higher. The risk is elevated while you're taking the estrogen, and as soon as you stop taking it, your risk goes back down. It's not like a permanent thing or a long-lasting thing. So that's why if patients are, they do develop a VTE, if you stop taking the estrogen, their risk goes back down to normal. So it's not like they need to be on like long-term anticoagulation therapy beyond like a month, a couple months of Eliquis or something like that. So, but yeah, this is just related to the estrogen by itself. It's not a progesterone problem. It's just an estrogen problem. Someone's saying, why would progesterone-only therapy take longer to regain regular ovulation? That's just something they find. I'm not sure of the physiologic reason why. With the depot shot, and that's the thing I commonly most think about in this situation, that makes sense because, again, the drug levels could be lingering for some period of time. You could have kind of low levels of that that medroxyprogesterone kind of sticking around for a period of time, even after that 3 months. So it could be a while till that drug is completely gone, and then you can get back to that normal cycle. But other than that, that's just kind of something they notice with therapy, is that it tends to be longer to return to that normal ovulation. But again, I always think about the depot shot being kind of the biggest culprit for that. Other things you could see, risk for things like MI. This is unlikely to occur in most patients, especially younger, healthier patients, but they're like smokers as well. Some of these things could kind of accumulate and kind of be synergistic with one another to worsen this. Certainly, if they already have atherosclerosis and all of a sudden you're adding an estrogen on board, which is increasing their hypercoagulability, then yeah, of course that could lead to that MI there. So some of this may be sort of long-term effects. But mostly this is going to happen in higher risk patients. So patients have pre-existing atherosclerosis, smokers, all of that. And then just the androgen effects of the progestins could also worsen things like the HDL, for instance. To go along with that, cerebrovascular disease, this kind of goes along with the clots, the PE, MI risk, all that. And then from a gastrointestinal standpoint, you could get cholestatic jaundice. This has to do with that recycling of the estrogen going through the biliary tract. This is something that can improve with time, but if you're going to see it, it'll probably happen within the first 3 cycles or so, right? So if they saw that, maybe OCPs maybe are not great. You can try a different route, but the oral ones are going to be the most likely to cause this. Now, in terms of like mood, for some patients, you'll find that depression may be helped with estrogen therapy to kind of help regulate their hormones, because again, you're supplying the hormones, so they're going to have very consistent levels. assuming they're taking it consistently. But for some people, it can worsen depression. So it really just depends on the patient. So you have to kind of see what works for them. From a cancer standpoint, again, you worry about risks for things like breast cancer. You tend to see this more so in like high risk patients, right? So that high risk history there, that'd be one thing to consider there. Cervical cancer risk is more so seen with patients with HPV, but they have higher risk for that anyway, and it depends on the subtype and all of that. And in the long term, they probably have reduced risk of things like ovarian endometrial cancer, and that has to do with having that progesterone in there, sort of suppressing, preventing that overgrowth of the endometrial tissue. Okay, so let me show you the different progestins here. So looking at this, you can see sort of they have different generations of them, and again, I don't care if if it's 2 pluses or 3 pluses or whatever, but just kind of see the general flow of the side effect profiles and how things have changed. So yeah, certainly you want the progesteronal effects here. That's good. But you'll see that from the androgenic standpoint, this is also where you get a lot of those side effects that I mentioned there. So not every progestin is going to be, built the same. And so for instance, like drospirenone, that's why a lot of people like this one, is because it lacks a lot of those androgenic effects, which is, you don't get the hirsutism, you don't get, the changes, negative changes in, or you don't get the fluid retention. A lot of reasons why they might like that. So I see a lot of people do well with that. Not that it's going to be great for every patient, but I do see a lot that prefer that. So contraindications, obviously they have history of like cardiovascular, cerebrovascular disease. These would be things you'd want to be very cautious with. Again, these are not absolute contraindications, but definitely things you'd want to investigate and think about. Certainly, they have an unknown cause of bleeding. Make sure there's nothing scary going on like cancer, any estrogen-dependent tumors. Obviously, this could worsen that. With heart failure, they could have increased fluid retention. So obviously, that would not be something you want to do there. Adolescents, you don't maybe want to give it too soon because, again, if giving the estrogens will close that growth plate early. So that could be one thing to consider. So not necessarily starting a patient too early on these products here. And then watch out for hepatic enzyme inducers. So it's like rifampin and phenytoin, probably the biggest ones I think about. If they are taking antibacterials, this is kind of a controversial one. I think I have a slide on this later on, but basically the thought being is if you're giving antibiotics, it can disrupt the gut flora, and that can impair that recycling of the estrogen because the bacteria will change the conjugated product back into the regular estrogen, and you can absorb that. If you disrupt that, the thought is those levels will drop and your risk for pregnancy increases or risk for ovulation increases. That's not been borne out in the data necessarily. You can't really do a study like that to randomize that sort of thing to see who gets pregnant, who doesn't, because that's kind of a long-term side effect of that. But it's sometimes you may hear recommendations to get backup contraception while on antibiotics. It just depends on the patient. It's not a guarantee they have to do it, but it's probably it's probably fine to do it. The risk versus benefits are pretty low there. Use some backup contraception. And then certainly if they're already pregnant, you don't want to be monkeying around with the hormones since that can affect the fetus for sure. As I mentioned, progestin-only contraception, is good for patients who are going to be bad candidates for estrogen administration. So if it's not recommended for them, then you can utilize progestin-only products. Cassette saying that's what happened to my boyfriend's mom. She took antibiotics with her birth control. They call my boyfriend the meant-to-be baby. That's interesting. We always talk about Phoebe as being a little surprise baby. It's very funny. It's like with your first kid. I don't know if this is like a universal experience, but I can just share mine. Like the first kid, it's like you're so like expectant, and you're just like, all right, when's it gonna happen? You're like you spend so much money on all these different pregnancy tests. And then when it finally happens, it's like, the angels come down on high and everything is great. And then for the second one, it's just like, my wife's kind of feeling kind of crummy. I'm just like, are you pregnant? And like, I don't know. So we, got a dollar store birth test strip, peed on, and sure enough, little Phoebe was there 9 months later. So, little miracles happen all the time. Anyway. So you'll see with progestin-only products, it's not as effective. So there could be some decrease in efficacy there. So that's one thing to warn patients about. And you will see more abnormal bleeding. That tends to improve with time, but amenorrhea is fairly common with these products as well. And as I mentioned, the delayed return ovulation. I'm more thinking about with the depot shots, but it could happen with the oral products as well. Someone said, would you like us to know each progestin name in the chart or what their specific side effect profile is, or just the general idea? I'd like you to be able to recognize the different progestins and maybe which one to switch to. If they're having a lot of androgenic side effects, like which ones would be a good one to switch to, right? Those are things I want you to kind of consider with that. Can low-dose hormone therapy be used while pregnant? It's not routine. If there is, I don't know the special cases for that. That might be a good question for Professor Lack or an OB-GYN professional. I'm not aware of any specific things, but I haven't honestly looked that far into it. So, yeah, as a second child, can confirm. My mom said the same thing. Yeah, I'm a second child as well. So, miracles happen all the time. Looking at me right now. Just kidding. More of a curse to you guys than anything, I would imagine. Okay, so let's see here. So another thing to consider too is post-coital contraceptives. Yes, middle children unite, absolutely. So post-coital contraceptives is like your Plan B, your morning after pill you're sort of thinking of here. You'll find these either it can be estrogen by itself, it could be progesterone only, it could be a combination, just depends. The big thing here is time, right? You want to make sure that they're getting this in within a certain time frame. These tend to be like 99% effective within 72 hours of the actual the act itself, right? So if they can get within that time frame, then it should be effective there. Note here that typically you're given like pretty big doses of these products here to basically kind of just flush out that whole system, and you'll find that nausea, vomiting is very likely to happen with that. And so, for instance, if they get like a Plan B, so I kind of highlight here, levonorgestrel. So this is kind of a common one you're going to find there. So like the one-step plan, notice it's a fairly big dose. Usually you're dealing with fractions of a milligram here, but for this, you're just giving it all at one time. If they vomit that pill up within the hour, they may not have absorbed it all, and that may lead to potential pregnancy. So this is a case here where I normally say if they vomit within the hour, I would take it again, right? So, or if you can give it with like an antiemetic, that would also be very beneficial. But a lot of patients have access to this over the counter now, so they may not be seeing you necessarily, but it could be a thing to recommend if they're seeing you about this issue, right? Someone's asking if there is a chance that BCPs could cause permanent infertility. I'm not aware of any specific risk. I'm not saying that couldn't happen, but it's not necessarily. Trying to think. Not that I'm aware of. I'm sure you could do some research to see if there is a risk there, but I'm not aware of what it is if there is one. So usually not. You could have delayed return to ovulation, but it shouldn't be a permanent thing for vast majority of patients. Some said, what's the mechanism behind the morning after pills? Basically, you're trying to get in and make it really inhospitable for the. So if fertilization has occurred, you're trying to prevent that implantation from happening. You're trying to prevent that, the actual implantation from happening. So by giving these like mega doses of estrogen and progesterone together, you're kind of like getting that environment very unlikely for that, or decreasing the likelihood for that implantation to occur, and then they can just eliminate it and get rid of it. So that's my understanding of the process. There might be a little bit more to it, but that's kind of the big thing. It's just preventing the implantation from happening. Because again, you can do this as well. One other thing that I'll talk about a little bit later is things like a copper-based intrauterine device. That's another thing that you can use potentially that can be used to as a morning after pill, so to speak. Even though it's not a pill, it's something you have to place within the uterus. It's just making the environment very unlikely for any implantation and development of a fetus to occur there. Someone is definitely getting fancy with all the stickies for sure. Failed to peel off the sticky. That's not good. I can't get rid of the sticky. Yeah, so someone is asking about slide 108. Would levonorgestrel probably have the most likelihood of having androgenic effects? Yeah, but you'll actually find it's a very common one you're going to see in a lot of different products there. So not everyone's going to get a ton of the androgenic effects, but if they experience that, that they can switch over to, there are other alternatives. Sometimes it depends on like the cost of the product, what their insurance is going to cover, etc. So that could be a determining factor on which progesterone you're going to be using there. Holy schmoly, there's a lot of questions up here. See, this is always the one that people have a lot of questions. So if I go over, it's your guys' fault. I'm just kidding, it's fine. And if I don't finish it today, I'll certainly get to it before the review. So we'll just finish up what we need to then. Someone said, I heard if you take Plan B a lot, it can affect fertility. Do you know if this is true, the mechanism behind it? I'm not familiar with that, but honestly, I haven't looked that far into it. So I'd have to do some research to know if that was actually an issue. But again, if you would check out Up to Date, you can look at articles about emergency contraception. Check that out, and they should have information about that if that is a concern there. Let's see. Yeah, so let me talk about the cycle scheduling in just a few moments here. I will get to that. Jackson is still, that's good to know. Good to know. Anyway, someone said, aside from giving with antiemetics, is there anything that can be done in order to prevent nausea, vomiting in the morning after pill, like eating on a full empty stomach, taking a certain amount of fluids? I don't know that I would tell them like eat like a full English breakfast along with their morning after pill if that is going to help it or not. Really, an antiemetic. And again, it's not everyone, it's like 40%. So, it's a decent number of people, but, if they want, they can try taking it with some food. But, and again, depending on the patient, this may be something that's just like a one-time deal. They need it, right? So I don't know, they can get a lot of experience of taking it with or without food and finding out what works for them, but it just depends on who's getting it, right? Let's see. Yes, I answered that. Okay, so I'll talk about that in just a moment too. So I have to go with scheduling. Okay, so as I mentioned, there's other benefits here to hormonal contraception. So things like reduced risk for ovarian cysts. It can help out with like ectopic pregnancies, or reducing the risk thereof. Iron deficiency is interesting because it actually reduces the amount of bleeding you're having. So you're losing less red blood cells, losing less iron. So it can help out there. Interestingly, it reduces risk for RA, which again, I don't know the mechanism for that. And then, as we said, endometriosis, acne, hirsutism, a lot of this is very dependent on the patient and what products they're receiving. Some patients are going to have worse than acne, right? You may need to switch around the progesterone and see what's going to work for them in a lot of those cases. So someone said, you mentioned something about OCPs causing increased UTIs. Can this be depend on the specific type of birth control / pill? I think this more has to do with the estrogen effects. If you kind of think about like a pregnant patient, how their corpus luteum initially, but then like the actual placenta develops releases a lot of estrogen and progesterone. Like those levels are really elevated during pregnancy. You're going to find that you'll get that urethral dilation. So I think it more has to do just with having the estrogen around is what causes that to occur. So I don't know if it's specific to any one product. I think it's more just like a general effect. You guys have really good questions. But anyway, so starting with a combo pill is most likely what you're going to be doing for most patients. You probably wouldn't start off with a progestin only unless you had a really good reason to do so. And then you're going to be using the lowest effective estrogen content possible. So usually like 30 to 50 micrograms of ethinyl estradiol is pretty common there. And then you kind of find out what's going to be acceptable in terms of side effects there. And so you can do like a 3-month supply to see how they're going to tolerate that. Stuff that happens initially should sort of even out, hopefully, if it's going to even out for your patients there. So things like, bleeding and things like that, you're going to, it'll either improve or it doesn't. And then at the end of that 3 months, you can decide to switch if need be. But just because they have it in the first month doesn't mean they'll continue it all the way to month 2 and 3. Okay, so let's talk about scheduling real quick. So, and this is like black magic stuff. When I learned about this, I was like, you can move their period around. You can eliminate it completely. I thought it was wild, but pretty cool stuff, I think. So starting oral contraceptives, they always say start the first Sunday after the onset of menses. And you're like, well, what's so special about Sunday? Why do you start it on Sunday? Well, I always thought it was weird too. It's like, is there something, like take it when you go to church or something? I don't know, right? Anyway, what the point of that is that it avoids withdrawal bleeding on the weekend. So that way, by the time you get to your placebo pills, by the time you'll basically go through the work week, that withdrawal bleeding will occur, and then it should finish up by the time you're getting to the weekend, where you're more likely to be doing leisure activities and things like that. So that's why they do that. Now, if the patient doesn't care, then there's nothing special about Sunday. They can start taking it any day they want, right? Post-pregnancy, they normally wait about 3 to 4 weeks or so post-delivery, and they can start it then to get them back onto their normal cycle there. And then post-abortion, you can just start up normally, so you can do it the first Sunday or they could do it the day of. It doesn't really matter at that point there. So in terms of someone was asking about the morning after pill. Someone's asking, will it disrupt or delay their upcoming cycles? It could have some effects on there, but if they are, for instance, needing to start go back on birth control after the Plan B, they can start it whenever. There's not like any waiting period or anything they have to do there. So hopefully I addressed that question. Let's see. So in terms of like using alternative methods of birth control, so either like physical barriers or something like that, some people feel that by to use backup contraception during the initial cycle, that's not necessarily necessary. It sounds kind of redundant and repetitive, but you don't have to use backup contraception during that first cycle. Some people feel like, well, you're giving your body time to kind of get used to it and kind of kick in. So that's controversial. They don't have to. Is it bad to recommend use backup birth control? Probably not. There's probably not a lot of downsides to that, really. If they have missed pills, and I'll talk about missed pills here in just a second, but also if there's concern with like severe diarrhea or antibiotics, that could disrupt that recycling of the estrogen, leading to lower levels, and so you may want to recommend that in those cases there. Again, the downsides are they accidentally get pregnant. The upsides are, the risk is they accidentally get pregnant if they don't do the backup contraception. The risk of using the backup contraception is pretty nil. So I think overall you're going to be favoring the benefits here of avoiding the accidental pregnancy. So for missed pills, so this is why they tell you to take it at the same time every day. So someone had that question there where they said, okay, well, let's see. So why did providers say to take their birth control pills at the same time every day? The reason for that is just consistency, right? There's nothing, it keeps good consistent levels, but also keeps the patient taking it the same time every day. So if they do it when they wake up in the morning, they wake up, take their pill, right? So it keeps the schedule, keeps them compliant more likely if you can stick to that schedule there, right? And again, not every patient is going to be perfect at this, but it helps, okay? Switch over. So in terms of missed pills, for just a single missed pill, just take it as soon as you remember. Again, the timing is not the most critical thing there as long as they get in during that day. If they miss 2 pills, then I would say take 2 a day for 2 days, and that would get them back on the schedule, and that's going to be fine. If you want to recommend additional contraception, that's fine as well. If it's 3 or more, then I say just go ahead and DC the rest of the pills and just restart on the next Sunday or whatever day they would normally want to start it. Just go ahead and get rid of it. Okay. So by doing that, you can go ahead and avoid any, that lapse is big enough when it's 3 or more days that it's like, okay, just go ahead and forget. Let's just start a whole new pack at that point. Okay. Now, if they have a missed period, so if like a failure of withdrawal bleeding and they've not missed any pills, I wouldn't say rush off to get a pregnancy test right away. But after if they say they haven't missed anything, I would say, okay, after the first one, give it a chance. If it's after the first one, they'll probably do it anyway, because if they're concerned about pregnancy, you want to know. But I would say you as a provider, if after the first one, I probably wouldn't necessarily worry all that much about it until if they missed it twice in a row, then I would get concerned. The rescheduling aspect of it is interesting. This is called honeymooning, because people usually don't want to be on their period when they're honeymooning. So this is where you can actually reschedule their withdrawal bleeding to happen when they want to, right? So in this case here, you can have patients just skip the sugar pills, skip the placebo portion, and just continue on to a new pack. And that way, whenever they get back from whatever event happened where they did not want to have any menstruation occurring, then they can go ahead and skip it for 7 days basically, and then start a new pack at that point. Okay. In terms of stopping, you don't really need rest periods. So there's not really, it's not like you have to take it for a year and then take it off for a year. It's like you can just keep on it and it's no problem there. Right. And then in terms of like desired pregnancies, some people say, give it 3 cycles or so before you really start to get concerned. But most people will return to ovulation pretty quick if they're taking a typical oral contraceptive there. Okay. So again, so in this case here, like you say, they'll just skip it and just go on to the new pack. There's products that are designed like that. There's something called like Seasonique or Seasonal, where they're designed to only have bleeding 1 time a year potentially, right? Or they'll just do it 4 times a year, whatever how they want to schedule it. So again, long-term effects on fertility, not really sure, but otherwise they're not going to have any other big issues with that. Let's see. So I think it goes back to the fertility issue. Yeah, so not really any big issues there in terms of suppressing normal withdrawal bleeding, less often, right? There's nothing magical about having 12 periods a year. If you can reduce that, there's not really any big issues as far as I know.
Oh, someone said, I realize this OB-GYN block, but we at any point discuss male contraception and the emerging possibilities of that. I don't go into that like real in depth, but we'll talk about male stuff when we get to urology later on. And we'll talk about androgens when we get to the endocrinology sections. I kind of break it up in two places there. This is all about the ladies right now. Not necessarily though, right? It could be for people that are taking contraception, oral contraceptive products who are men, right? You have transgender patients and all of that. So again, not just for the ladies. Some say, can you take oral contraceptives when breastfeeding? I believe you can. I'm trying to think. There's not. I don't know if there's any contraindication. It may inhibit lactation, so you probably wouldn't want to do it from that standpoint. So I would say, if you can use an alternative, that would probably be good. So if you can use something like an intrauterine device or something, that would probably be beneficial from that standpoint. Anyway, so just one more thing. Yeah, so breastfeeding does sort of have a natural process. If you think about it, prolactin is a natural inhibitor of pregnancy too, right? So if you think about patients who have like prolactinomas or yeah, so if they have high prolactin levels, that oftentimes will inhibit their ability to become pregnant. So it's not a foolproof method though. So I would not bet the farm on just using that. So yeah, exactly, Allison. So in those cases there, and again, that's why you can find for some patients with infertility, they'll receive a dopamine agonist. They'll get something like bromocriptine because that reduces prolactin levels and that could cause ovulation to occur. So yeah, so your mom got pregnant with you while breastfeeding 2 months after giving birth. Right, so it helps, but it's not perfect, right? Yeah, you ladies do have a rough. I became much more feministic when, or more of a feminist when my kids were born. Girls have a tough time of it. What I meant about fertility is that the patient may have a problem getting pregnant in the future with having birth control every 3 months. Help them get pregnant in the future because they are not shedding their eggs. I'm not. I don't think there's any issue with that, as far as I know. I would have to do some further research to know, but I'm sure some up-to-date articles could help out with that. Someone said, not sure if you've already talked about this, but when someone first starts BCPs, is there a length of time for the effects to take place, or can they stop using backup birth control right away? That's why I said it's controversial. I think it's not bad to recommend backup for the first month, but after the first month, they absolutely should be good to go from that standpoint. So, like I said, is it bad to recommend backup for the first month? No, but it's probably not completely necessary. But again, what are the downsides? Accidental pregnancy, it's not great. Mom had 4 kids in 6.5 years. Yeah, those Irish twins, as they say, right? Okay, let me see if I'm trying to find a good stopping point for you guys. I know I'm going over already. Mm, okay, so I'll just finish up on this slide here, and then I'll finish it tomorrow. But for breakthrough bleeding, as I mentioned, during the first 3 months, that's why I give 3 months trial for these, is it will generally resolve over time. If not, then you consider switching. If it's still present, though, you can actually modify the product that you're using based on when the bleeding is occurring in the cycle. If it's early, so if it's in the first 2 weeks, is generally due to an estrogen deficiency. You can give them a bigger dose earlier during the cycle, right? And that typically happens with like bi and triphasic products. We'll start with a lower estrogen dose and then generally work them up. And I'll go over these tomorrow when we go over the products. And then if it's bleeding towards that third week, then it usually is due to a progestin deficiency. So you can actually give more progestin, and that will help out in those cases there. So that's how you can actually modify that. So if that's a test question that said, a patient's having bleeding during the first week, they've been on this birth control for 3 months, what do you want to do? Do you want to give more progestin? Well, no, because it's early, so I'd probably want to give more estrogen. So I may have something where I say increase estrogen, increase progestin, decrease progestin, and that's how you kind of have that. It'd be like your answer choices, right? So just as an example, how I could do that. So anyway, so I'm gonna go ahead and I'm gonna cut it off there. I will finish this tomorrow when we do our review. So that'll be via Zoom. So I'll see you guys all online then. Thank you for your questions. If you have any more, post them up. I'll talk about them tomorrow, and then we'll go from there. So otherwise, thank you so much for joining me. I really appreciate you guys being interactive. It makes this much more fun for me. And yeah, so I'll see you guys tomorrow. Have a great day. I'll see you this afternoon, actually. I'll be there at lab, so I'll see you at like 12:30ish. Yep, see you later. I'll be the one wearing the mask in lab. That's how you'll recognize me. Just kidding. All right, see you guys.